friends. This will be a talk on one of the USMLE's favorite topics when it comes to medical ethics, and that is the withdrawal of treatment. When do we do it? How do we do it? When's it okay? When's it not okay? USMLE loves to test this when it comes to ethics, so you'll want to pay attention here. Furthermore, if you were trained outside the US, some of the answers might be a little bit different than what it might be in your home country for your own licensing examinations there, so you'll want to pay attention to this. Just in case there are some differences. For the most part in the Western world, you're going to pretty much have very similar ways we go about doing withdrawal of treatment, but there may be some minor differences. So this will be good for you if you are planning on taking a U.S. medical licensing examination. If you haven't had the opportunity yet, please consider subscribing to my Patreon page at www.patreon.com/pwbmd. If you could consider chipping in $1 a month, those little contributions go a long way to help keep these videos free. You can get there by clicking the I button in the upper right-hand corner of the screen or on the link below in the description of the video. If you subscribe, you'll have access to some of my premium videos in which I go over case studies, reviews, formulating differential diagnosis, and treatment plan, things that will come in handy for you for clinical practice, and particularly for that step 3 of the USMLE, which has a non-multiple choice section. So we are going to talk about some important definitions, and by talking about these definitions, it will give you an idea as we talk about them about how important these things are, and really just knowing these definitions is going to be useful for you. Then we'll talk about some principles and pitfalls, some of the more commonly tested situations and scenarios, things that may differ in this country compared to elsewhere. So you'll want to pay extra close attention to that. And then we'll talk about some relevant cases. You can stop watching if you want at that point because it's zero yield for the USMLE, but it is interesting, gives you an idea of how we got to where we are today. So the first definition is competence, something that we alluded to when we talked about our general principles of medical ethics. Competence is something defined by the court. So you do not determine whether a patient is competent or not. That is done by a judge. You can certainly determine whether a patient is incapacitated. So if they are unconscious, certainly they're incapacitated. If they're in a coma, they're incapacitated. But you really can't judge whether or not they are competent. At least formally. You can informally determine competence. Obviously, if the patient has an active psychosis or a known suicide attempt as part of their presentation, then you can safely assume that they are incompetent and that a judge would agree with you, but you do so at your own peril. So it is defined by the court, hence the patient should be deemed competent unless there are clear behavioral signs to suggest otherwise, wherein you would, if you were to deem that patient competent, it may lead to some seriously bad outcomes. So sending a patient home who's suicidal, sending a patient home who's actively psychotic, that would obviously be a bad move. So patients are deemed incompetent by the court. When they are deemed incompetent by the court, they'll typically be assigned a surrogate decision maker to make decisions for them until they become competent again in some cases, or in other cases like dementia, Alzheimer's, they won't become competent. A lot of times that surrogate decision maker is a family member, but I have worked in the inner city where you have homeless people. We really don't know any next of kin. They are typically assigned a caseworker. An advance directive is a legal document indicating the person's wishes for care, especially should they become incapacitated. So this typically comes down to things like artificial hydration, nutrition. Do they want a feeding tube? Really concerned about some of the more problematic things like being in a persistent vegetative state, which is something we'll talk about in a little bit. An advance directive is also known as a living will. You hear that term thrown around a lot more by lay people, but in the medical community, we refer to this as an advance directive. Usually, like I said, it includes information regarding artificial hydration and nutrition, whether or not they want to receive that. And it also includes very, very important information, which all of us should have documented, and that is, who do we want to make decisions for us should we not have the ability to make decisions for ourselves if we become incapacitated. And that person is known as the designated power of attorney. They can be absolutely anybody you want. It could be President President Trump, although I have no idea why you would want to do that. It could be absolutely anybody you want. That person may defer and say that they're going to not be the one to make decisions, and they can certainly do that. So if your designated power of attorney is your daughter and she decides she doesn't really want to make the decisions, she can choose then who will be the designated power of attorney for you. So it needs to be someone that you trust. Do not resuscitate or DNR orders, also a legal document, but this is primarily drafted by the hospital or the clinic, and this indicates a person's desire to not receive CPR and or advanced cardiac life support should the heart stop beating or breathing stops. And this is just a code, right? So it's whether or not we want to take extraordinary measures like defibrillation and codes in case a medical emergency comes up. And in most jurisdictions, it has to be co-signed by a licensed physician. So you don't just get to write this in your will. Typically, you need to do this in consultation with a physician. It needs to be a licensed physician too. So first-year residents, you're not going to be doing this. But once you pass step 3 and you get your medical license, then you will be the one to help patients out with this. Really, we talk about DNR orders when we're talking about patients who are very chronically ill, in and out of the hospital, have serious medical issues, usually much older patients, or it could be cancer patients, I suppose, but people who are very, very ill. You're not going to have 22-year-old healthy people coming in and signing a DNR order. I certainly would not co-sign on a patient who had wanted to do that. I think that would be a really bad idea. So this is an example of a healthcare directive, also known as power of attorney and living will. These are advanced directives. This is an example of one that comes from state, but you can have a variety of different templates. So there's millions of different ways that you can write these up. They're not always in the same format, but you can see here a person can determine what they deem to be an acceptable quality of life. If they're in a persistent vegetative state, do you want to get life support? Or maybe you do want to get life support even if you are dependent on others for daily care, but you don't want to get life support if you're in a coma, for instance. So it gives you an idea, it gives you options of when you want to receive such life support. So it gives you a lot of laterality. So this is something, like I said, I recommend to patients who are older anytime they're at an age where they could suffer a massive heart attack. So it's something I recommend to all my patients really over the age of 45 that they start thinking about this. This is a DNR order. See down here, it needs to be signed off by a physician. So as we kind of alluded to, this persistent vegetative state, you see it come up in the news a lot. It is referred to in first aid for USMLE Step 3, so it is something that you do need to be aware of. The problem with persistent vegetative state is we really don't have a great agreement on what makes a persistent vegetative state. So I used the definition from the American Academy of Neurology, which says that it's a vegetative state lasting at least 1 month after some kind of inciting injury. And that could either be an external injury like a head injury, or it could be something like a stroke or any kind of prolonged lack of oxygen to the brain. It gives a definition of what a vegetative state is, and I think we've all heard of what a vegetative state is. Basically, you've got a person that looks conscious but really isn't. Their body is functioning, but their mind is not there at all. They have no self-awareness, and it can be really deceiving to families, people that don't have an idea of what this persistent vegetative state is, because it really looks like the person is awake and responding when in fact they are not. So typically it's neurologists who will diagnose this. So this is definitely not something that you need to know for the USMLE. What you do need to know for the USMLE is that it is possible for a patient to look entirely conscious, but also lack any awareness whatsoever. USMLE will not ask you to diagnose persistent vegetative state. You just need to know that it exists and that it can be very illusory for family members, and that can be really unfortunate and tragic for them. Withdrawal of treatment. So this is the talk of the lecture, but this is a very important definition here, even though we have all these other peripheral definitions that we're introducing. So withdrawal of treatment is simply discontinuation of life-sustaining treatment. So that could be, it's often things like a respirator or maybe certain medications that are important for keeping the patient alive. Really, it's different from never starting or certainly offering treatment. So you always need to offer treatment. It's really up to the patient as to whether or not they want to start it, but you always need to offer the treatment and certainly counsel them on what are the risks if you don't take this medication. Do you understand the gravity of the situation? Some discussion that you need to have with them and document that you had with them. Sometimes there are misperceptions if they are going on, if it's a cancer patient going on chemotherapy, they may think, they may have misperceptions as to what the chemotherapy entails. They need to have all their options laid out for them before you go ahead and say we're going to withdraw any kind of treatment. There's a decision-making hierarchy. Obviously, the patient is number one. Then whoever's listed on the advanced or whatever's listed on the advanced directive should that patient become incapacitated. If there isn't anything or there's issues that are not made clear by the advanced directive, then it goes to the power of attorney. And the power of attorney really speaks with the voice of the patient if the patient is not capacitated and the advanced directive doesn't address the particular question at hand. Then it goes to next of kin. So often it goes to next of kin when a power of attorney is not listed. The next of kin will always be the spouse first, and then it goes to children after that, and then to parents. So next of kin is important. Sometimes the next of kin's not there. Having worked in an urban hospital in the past, we've seen lots of homeless patients who come in, no family available. That can be really problematic. If you can't get a hold of anybody, patient's incapacitated, no advanced directive, no power of attorney, no family available, then typically it goes to the physician, at which time you also need to get a court order, and typically the court will appoint somebody to make the decisions, but you may need to make those decisions in the meantime. Generally, you're going to err on the side of preserving life for a multitude of legal reasons, which I'm not going to get into here. Withdrawal of treatment is not the same as withdrawal of care. So this is really just a philosophical thing. Just because we're withdrawing treatment for the disease does not mean that we would stop caring for the patient. And this gets down to hospice. We're kind of talking about some end-of-life things here, but we can make a patient comfortable even though they decide they don't want the rigorous treatment for their disease. So things like pain medication, if they have some kind of disease that's very painful, though they don't want to get treated for the disease, maybe they just want to be comfortable and let the course of nature take place. Okay, this is very, very, very important. We're going to get to two things that get very commonly confused, and even though the USMLE will not ask about whether or not these things are legal, it's very possible that they will ask about if you know the difference between the two of these, so you want to pay attention. Physician-assisted suicide. So this is on the part of the physician, the provision of the necessary means to enable the patient to perform a life-ending act. So you're providing pills for the patient to end their life, knowing that the patient intends to do this. So obviously this is not the same as giving a patient medication and then they take a ton of it and kill themselves. This is actually giving the patient medication and instructing them how to take it in a way that will end their life. That's why they call it physician-assisted suicide. You're not doing the killing, so to speak. The patient is. You're just providing them with the means necessary. So the active actor, and here we're getting into some old school philosophy, metaphysics, but the actual actor is the patient. They're the person that's actually actively killing themselves or doing the killing. So the patient performs the life-ending act, but they are assisted by the physician. That's why it's called physician-assisted suicide. This is a practice that is legal in some states, as you can see, Washington, Oregon, California, Colorado, I believe that's Vermont, and then also Hawaii, and then Montana. It is legal under court ruling, but elsewhere in the U.S., in the majority of the country, it is not legal. It is also legal in a variety of countries, but that's beyond our scope here. It is a topic of public controversy. It tends to enjoy a good amount of support by the public. As a matter of fact, in Colorado, it passed by referendum. So this is something that you'll expect to hear more of. But we're really talking about whether is it maleficent to provide something that will harm a patient, ending their life, or is it beneficent to deliver them from their suffering? You got two conflicting medical ethics that you really have to take into consideration. And this is Brittany Maynard. She was lived in California. I believe she had cancer. At the time, California did not have assisted suicide, so she traveled up to Oregon and ended her life. There's, like I said, lots of ethical questions about it, but that's all I'm going to say about that. So, as you can see here, and also legal, I believe, in Washington, D.C., according to this. Okay, so that was physician-assisted suicide. This is euthanasia, and this is totally different. Euthanasia is the termination of the patient's life by the act of the physician. So this would be like you going and giving them a lethal injection. Even if they ask for it, the fact that you're the one that's doing the act that's ending the life makes it different from physician-assisted suicide. So it's all about the actor here. Here it's the physician actually doing it. So this may be an unconscious patient who had in their advanced directives that they want euthanasia, even though it's not legal in all of the U.S., but that's still different from physician-assisted suicide. So that's a very important distinction. It's about the actor. Who's the one doing it? If the patient is taking pills, even if it was provided by a physician, that's physician-assisted suicide. If the physician is administering the medication or the drug that's ending the patient's life, that is euthanasia. Important distinction, voluntary versus involuntary euthanasia. Involuntary euthanasia is never legal anywhere in the world. That would be considered murder, but involuntary euthanasia, quote unquote, was something that they did in Nazi Germany to get rid of the disabled population. Obviously an atrocity. Involuntary euthanasia is really a misnomer. It's really just murder. Voluntary euthanasia is where you have the patient's consent. That is something that is legal in some places. As a matter of fact, it will be legal in Canada soon if it's not already. So if you're a Canadian taking MCCQE, obviously you would want to take that into consideration for your situation up there. It is not to be confused with passive euthanasia, which is a really awful term because it's really the term a term that refers to just general withdrawal of life-sustaining treatment, which we call withdrawal of treatment. So I don't like the term passive euthanasia. You shouldn't expect that to come up on the USMLE, but if you see that thrown around in the literature, that's what it's referring to. And euthanasia is not legal anywhere in the U.S. There are talks about it, though, in certain states. It certainly, as far as I know, would not be illegal on a federal level for a state to legalize euthanasia, but we just haven't gotten to that point yet. Again, very ethically charged topic. It is legal, I think, in the Netherlands as well, so you see people going there. I think Belgium is another place. So some principles. Always assume that the patient wants all necessary life-sustaining care unless there is legal evidence suggesting otherwise, or the legally designated decision maker, i.e. the designated power of attorney, refuses care. It says that the patient wouldn't want that. Minors are a special case. So this is very, very, very important. This is where the U.S. may diverge from other countries. So in the U.S., patients cannot choose to withdraw life or limb-preserving treatment for their child, even for religious reasons. Parents typically have a very wide laterality on whether or not they want their kid treated for something. So, if it's something like having their tonsils taken out, a parent can either choose to go ahead with that or not to go ahead with that. When it comes, however, to life-preserving treatment, even for religious reasons, they cannot choose to withdraw that. So even something like a blood transfusion, an adult can choose not to receive blood, but a parent cannot choose for their child that they don't want the child to get blood. So very, very important caveat there. If the parents are not available, obviously you treat. If it's emergent and the parents refuse, you're going to treat. And in the meantime, you're going to get a court order. If it's non-emergent and the parents refuse, then you'll want to counsel them first. You want to avoid court as much as possible, believe me. And then you'll also consult the hospital legal staff, and the court will get an order that will declare the child to be a ward of the state, and you'll treat as necessary at that point. So when it's emergent, go ahead and treat. If it's non-emergent, but it is a life-preserving treatment, so like chemotherapy, for instance, in that case, you need to first counsel the parents, and then meanwhile go ahead and go your legal avenue as well. But hopefully you can try to change the parents' minds before having to go the legal route. Very important also, children cannot refuse treatment. So let's say the parents want the child to receive treatment and the child says no. If they are a minor, they cannot refuse treatment. They are obliged to receive that treatment. Once they turn 18, they can make that decision for themselves. The designated power of attorney is the ultimate decision maker. If the patient is incapacitated, as I said, they speak with the voice of the patient. So they are basically the number two. If and only if a power of attorney has not been designated, then you will defer to the next of kin. And a lot of times the power of attorney is the next of kin, but if you don't have a power of attorney, then it goes to the next of kin. A lot of people don't have a power of attorney. So the next of kin would start out as the spouse, then it would be the children, then the parents, then the siblings, and this all follows. There may be some variations from state to state, so I don't think you'll be tested on that in the USMLE. But this typically follows inheritance laws. If no one is available, then your goal is to preserve life through all necessary means until a legal resolution is available. This is not going to come up on the USMLE. So what you do want to know is that the power of attorney does speak with the voice of the patient if the patient is incapacitated and there's no advanced directives available for the particular situation. Some pitfalls that students run into on tests and wind up getting the wrong answer. One, they have the impression that life must be preserved at all costs. Obviously, we do want to preserve life, but unless the patient is deemed incompetent, the patient has an absolute right to refuse care for themselves. Two, confusing withdrawal of treatment with medical negligence. It is negligent to fail to offer treatment, but it is not unethical to withdraw treatment that's already been started or that's been offered and has been refused by a competent patient. It's also unethical to impose treatment on an unwilling, competent adult. So you need to bear that in mind. Another big problem for students taking the test is confusing euthanasia with the provision of medically justified comfort care. So for instance, if you have a terminally ill patient and they are in pain, and you were to give them pain medication that might have the unintended consequence of shortening their life, that is not euthanasia. That would be considered ethical under the principle of double effect. So euthanasia, our laws against euthanasia does not mean that we have to avoid anything that might have the unintended consequence of shortening the patient's life. It just means that that cannot be our intent. So the way that you know that you're avoiding getting into a euthanasia-like situation is as long as you're prescribing things like pain medication in acceptable doses. You're not going overboard with that. That's where you would cross the line into euthanasia. Withdrawing life or limb-preserving treatment for a minor due to parents' wishes. You have to always preserve the life of the minor, even if the parents refuse, you would want to obtain a court order. And then also, assuming a minor can consent to treatment or refuse treatment as an adult can, they cannot. And I think, so this is Dr. Kevorkian. He spent 8 years in prison for doing euthanasia on a patient who was charged with second-degree murder and convicted. So some people think he's a hero, other people think he's a murderer. It really just depends on where your ethics lie. But according to our legal system, he is a murderer. So you can stop watching if you want at this point. Everything I'm going to go into now is not relevant for the USMLE, but it does give you an idea of how our system kind of formed based on case laws. Obviously, we have a common law system in the U.S., so a lot of our quote-unquote laws are really made by the court. Because they set the precedent, how we interpret the laws and how we interpret the Constitution. So in regards to the Quinlan case, you can look up Quinlan. She was, I believe, back in the 1970s, was a young woman who had alcohol and also sedatives one night, and then she wound up not breathing and ultimately ended up in a vegetative state. So the New Jersey Supreme Court came up with this principle called the substituted judgment standard, which means the decision can be made for an incapacitated patient if it can be reasonably demonstrated that the decision is what the patient would want. So even if there's no power of attorney or anything like that. So that was the Quinlan case. Again, you can look all this stuff up. I'm not going to delve too much into this. I'm not a lawyer by any means. Then we have the Eichner case. This was decided by the New York Court of Appeals in 1981. They set up a different kind of standard called the best interest standard, and that simply said that the state has a legitimate interest in asserting its powers over the mentally incompetent, both to provide care and to safeguard the best interests of those who are physically unable to care for themselves. The Baby Doe Amendment was a very important amendment that came about in the 1980s, which really established how we approach children, life-saving, life-preserving interventions for children, and it expanded the laws defining child abuse to the withholding fluids, food, and medically indicated treatment from disabled children, and ultimately this expanded with additional amendments. So this got passed in the 1980s under the Reagan administration. The Born Alive Infants Protection Act, which is relatively recent, about 15 years ago, signed into law by President George W. Bush, defines an infant as a person if it is expelled alive. Now, we think, well, a baby's born, it's a person, right? Well, if the woman, the mother, was trying to have some kind of an abortion, late-term abortion, or let's say that it was a second trimester abortion and the baby happened to be born with a beating heart. If that is the case, it is case closed. That is a person. That is a human being. Even though we don't consider a fetus to have human rights, that infant that is born, even if it's in the act of trying to do a partial birth abortion, that baby is now has human rights and must be resuscitated, regardless of the desire of the mother. So if it's born alive, it is an infant. It has human rights. Obviously, if it's not born alive, then, So this does not get in the way of the legality of abortion. It just says that if an abortion is performed and that baby is born alive, in terms of beating heart, voluntary movements, that you have to take resuscitative measures regardless of whether the parent wanted to have that baby or not. And then this is probably one of the most important consequential cases. It was decided by the U.S. Supreme Court in 1990, and this was Cruisin Verse, Director of Missouri Department of Health. And this says that while individuals enjoy the right to refuse medical treatment under due process, incompetent persons are not able to exercise that right, and that you need clear and convincing evidence that the patient would want otherwise, that they would want discontinuation of care. And if you don't have that, then the state is allowed to intervene to preserve human life. So that we kind of, we take for granted. But another important thing that this decision set into precedent was that the right to die is not established by the U.S. Constitution, and hence left that decision to the states. Were this a different court, they may have they may have concluded differently on the right to die, which was an important question in this case, and that would have essentially established a constitutional right to physician-assisted suicide or possibly even euthanasia. The court went the other way and determined that there is no right to die, but it does leave the decision to states, and as we've seen in a handful of states, physician-assisted suicide is legal, and that seems to be a trend, especially in popular opinion. People want to have that decision to themselves as to whether they want to die, when they want to die, if they are very sick. And typically, I didn't really get into this because it's kind of ancillary, but typically when it comes to physician-assisted suicide, it is in the law that the patient has to already have some kind of terminal illness. So you can't just get up and say, well, I'm depressed, I'm going to go kill myself, and use physician-assisted suicide. It doesn't work that way. It does in some countries. I believe in the Netherlands you can actually do that, or Belgium, but that is not how it works in the U.S. You actually have to have a terminal illness, and you do need to, it does need to be signed. I'm not familiar with each of the individual state laws, but the ones that I do know, it needs to be signed by 2 physicians, not just one, and I think one of them also needs to be a psychiatrist, but don't quote me on that. Anyhow, that's all I've got for you. If you have any questions, please write me a note below. Otherwise, I will see you in our next talk.